Nothing like wrapping everything up at the end, right? But first of all, I've learned quite a lot, a new language with Tim and Danny, and Mike from Rwanda, if you're still in the room, maybe not, but I think in many ways Rwanda's ahead of us because they have had to be in some of their interesting approaches. But today, I think the reason Milton wanted us to talk was to really think about some practical applications and some use cases for telehealth in a local setting. And I hope that you'll find those as applicable if you're delivering care, if you're a provider. I'm not going to read this to you, but I have to say that that's what we had to do. We had to go back and say, what is it that we're trying to do when we talked about telehealth? We started talking about continuum of care and how do we do the touch points across all aspects of care, not just in the hospital. And we really had to figure out a different methodology or technology to really advance health. And so we had to think about that quite a lot. And for us, what we had to do is we had to say, what are we trying to do? And so we had to narrow our thinking and be very discrete and concrete, because otherwise telehealth can get you off into so many different tangents, we thought, for us. So we knew that some of our problems that we were trying to solve, a lot of it, of course, under the influence of the Medicare regulations and what have you, had to do with making sure that we were connected with care post-acute, so after a patient leaves the hospital. And also, how do we actually advance or accelerate some of the clinical decision-making, not only in the hospital setting, but in the SNFs, skilled nursing facilities, and in the home. And then second today, Margaret, my colleague, is going to talk about how, in fact, we've done some trials, if you will, in the home using remote patient monitoring. So for us, what we did is we did a gap analysis internally about what was happening with specific to readmissions, and a lot of you may have done similar work, and we'd love to learn from you. But essentially what we were finding is the handoffs were not going well. There was miscommunication, of course, and there were the discharges from the hospital to the SNFs were not always necessary, and then also the transition from SNF to home was very difficult and complex. And so what the list goes on that we didn't know who the PCPs were necessarily, information was incomplete, et cetera. And of course, MedRec, medication reconciliation, was not being done for the patients that we were serving. So when Medicare did come, of course, and they're incenting us now and penalizing us if we have too many readmissions, we also thought that was another reason to focus on this, and that we were having a higher than average 30-day readmission rate. And so a lot of you may or may not know that hospitals are penalized about 2%. So if half of your business is Medicare, that 2% of a big number becomes a big number and something we pay attention to. But mostly it had to do with the clinical issues that were just broken, and we didn't have the right connections in place between transitions of care, okay? So we did a lot of things, and what I find about telehealth, for us, I describe telehealth as an accelerator. It allows you to make more timely clinical decisions. It allows you to build relationships between a provider and a patient and provider to provider. And telehealth, for us, that's how we view it. So we view it as one piece of a very complex, if you will, diagram of how you care for patients at different points of health and well-being and sickness. So for us, the telehealth is really an accelerator and essential in our minds to staying in touch with patients and building deeper relationships with them and this back and forth interaction. So what we did, of course, is we didn't just do telehealth. We did a number of things to try to improve the communication and understanding between transitions of care. And so these are just a couple of examples I'm not going to read to you, but telemedicine was just one part of it. We basically established telehealth between the hospital and skilled nursing facilities. So if you just break it down, what we did is on every Friday, we had a geriatric, basically nurse practitioner, via telehealth, talk with skilled nursing facilities, and reviewed the high-risk patients that we had discharged from our hospital into the SNF. That sounds kind of straightforward. You make a lot of phone calls, you do that all the time. But what this did is it just changed the conversation. It's hard to describe. We actually built better relationships with those SNFs where we had telehealth in practice because we got to know the providers, because you never have time to go out to 20 different SNFs, right? So getting to know the people and getting to know what our shortcomings were, what our breakdowns were, as well as getting to know the educational levels, competency issues, and or communication issues at the other end, were largely solved through this ongoing face-to-face communication provider to provider. Margaret will talk about telehealth to the patient in the home, but this was provider to provider. And when you sit and talk about a patient face-to-face with the same care team every week, it just builds this relationship and this trust and this understanding that's different than a regular random phone call when you're trying to get through the day. It helps you focus on the high-risk patients where the focus needs to be done, we thought. And it really drove different results, quite honestly. It helped us actually bridge to these SNFs in a different way. We provided education for some of their staff. They knew our patients well. They kind of knew them, what our standards were. We talked about polypharmacy in a very different way, appropriate use of medications. We talked about clinical decision-making and more timely clinical decision-making. We talked about inappropriate admissions. It just gave way to a much broader conversation. So I know those are hard things to measure, and we tried, and I'll show you what we did. And I'm not saying that our results were a direct result of just telehealth. For us, telehealth is just one part of a lot of different things you have to do. And when I say telehealth is an accelerator, I think it's beyond that it provides a more timely clinical decision-making. I think you're also in the prevention business. Because what you do is you anticipate more when you have this open dialogue. You prevent what we think is maybe what could happen is a decline in health status if you actually have this ongoing dialogue. And so we feel that telehealth is an accelerant. It helps prevent complications with a different type of conversation. And I think what Margaret will point out is it also, for a patient, it really encourages ownership and activation of your own health behaviors. Because at the end of the day, we're all trying to affect behavior, which is impossible to do sometimes. But at the end of the day, we really want patients to own their own health behaviors, healthy habits, medication compliance, safety in the home, maybe nutrition. But at the end of the day, telehealth, when you have that real-time conversation, you have an opportunity, right, to really have those kinds of personal conversations. And that just is so different than having a primary care visit every 4 or 5 months or 6 if you're lucky. But it really does provide that real-time access. So for us, on the skilled nursing facility piece, it really helped improve our relationships. And in the end, for us, we had readmission rates. Now, these are just basically folks that leave the hospital and come back, for those that aren't in the healthcare or hospital world. But anyway, we had 10%, and it went up a little bit. We actually, I think telemedicine, and Milton wanted to make sure we mentioned this, the reason why, for us, it kind of fell by the wayside, and it did, unfortunately, is because other priorities in the organization took precedence. And just to have a connection with a SNF it does no good unless you really have the infrastructure and the commitment of the leadership and the physicians and the care teams who actually understand the benefit of what I just described. Because we're going to look at ROI. Well, one way to look at ROI, I guess, is to see whether or not you were penalized by Medicare that year and whether or not you met your goals. That's one way to measure it, of course, right? But oftentimes it's hard to pinpoint, it's just telehealth that really moves the dial. So it's still, I think we're learning a lot about how do you validate and verify, if you will, the benefits and value of telemedicine. For me, it's an essential ingredient, I guess, because I really saw the intangible work around activation of patients, the prevention aspect and anticipating future complications. But sometimes people have different views on that. In the end, though, for all readmissions, if you look at where El Camino stood in comparison, if you will, to benchmarks, El Camino had 13.9% readmissions, where the region was at 16.9%. In Santa Clara County, you see 18.5%. But the point, California was 18.5%. So that is statistically significant. Is it all because of telemedicine? I'm not going to say it is. But I think it's for people who think more broadly about what are the uses of technology and different ways to have the conversation with providers and patients that will influence and improve, if you will, patient outcomes and results. And we felt that telemedicine, even though Sometimes it is hard to sustain that commitment and interest. We feel it has a real place, obviously, and a permanent place, we believe, in connecting providers, and then Margaret will talk about connecting patients as well, more directly. Margaret?
Just goes up, the white. The top one. Oh, thanks. All right, thank you. All right, thank you. So I'm going to talk a bit about what work we've done doing remote patient monitoring in the home, as Tomi mentioned. And one of our big burning platforms was we started to participate in Medicare's innovation program, Bundled Payments for Care Improvement, in which we really had to control cost and utilization management because the hospital was, at this point in time, financially responsible for patients who discharged from the hospital and then for 90 days after that. So this is a pretty foreign concept for a general acute care hospital where we're not only responsible now for the patient in the hospital, but now once they leave the hospital and go to any number of various settings. So for us, making sure that quality was in place and we also reduced readmissions was really important. So our hospital put together a team who was responsible for developing a pilot in telehealth. And so this team was specialists, hospitalists, respiratory care, nursing, care management, and IT. And we had a lot of people very interested in this topic, so it was not difficult to get everyone involved. But basically, we decided we would do a short duration, small patient population pilot to really establish feasibility and hopefully positive outcomes before we try to roll it out on a more broad basis. And so we started with 10 patients. We decided we would have, again, only 10 patients, but also patients that were already patients we were at risk for. So we decided patients who had primary diagnosis of COPD. And the team then decided on the whole implementation process, which I'm going to go over in just a second. But partner selection was a big question here earlier. A couple days, I've heard a number of vendors wanting to know how did we select our partners. And basically, we had two partners in this process. One was Connected Home Living, which was the equipment company, and the other was a home health provider. And they actually approached us. So we didn't go through a rigorous selection process. They essentially had an off-the-shelf product that was ready to go. They had proven collaboration together, monitoring patients and managing patient escalation issues. And they were also willing to provide us the kits for free, so that was really great. So we decided we would partner with this team, try out the process that they had, and see what results that we could get. This is actually just a matrix to let you see the other diagnoses that we considered. Actually, initially, we had planned on having patients that had COPD primary and then pneumonia secondary, but we ended up having a shortage of patients admitted with COPD. So in the end, we just decided if patients had COPD primary or pneumonia primary. So we had to be a little flexible. So I'll run through the process, but before I get going on that, I also thought it might be helpful to know the kit. It was a fairly simple kit that was used. It really was an 8-inch tablet, blood pressure, pulse oximetry, weight, and then I guess the blood pressure. And then, the other thing that I think was really terrific is they had 90 care plans and then 1,500 patient educational videos. So I think it was a good beginning point for us. And also I think the patients really found those educational videos effective. So as far as the remote monitoring process goes, we had a nurse who was responsible for identifying patients in the hospital who first met the diagnoses criteria, and second were Medicare, fee-for-service, and then third were discharging home. And so after the nurse identified an eligible patient, she involved our respiratory therapy team, who would then go meet the patient at bedside and determine if they met a couple of key indicators. One was, does the patient have a CAT score of a 3 or a 4? And then second, did the patient appear cognitively and physically able to use the equipment and do the monitoring? So in the end, that actually eliminated a number of patients. So if the patient was qualified at that point, then our home health team would actually come and meet the patient at bedside, which was also a pretty important part of our process because we also found that patients didn't really want to have a stranger in the home, and they also didn't quite understand the benefits of the monitoring. So having home health come to the bedside and talk with the patient and sometimes family, it was really helpful in the adoption process. One of the things that I think is also pretty helpful about the Connected Home Living that we partnered with is that they have a remote care coordinator who was a big part of the care team. And this person's job was essentially to be the other person on the end of the video and talk with the patient daily. And actually in the first 14 days, they would make 2 calls a day and check in with the patient, which turned out to be a pretty important part of preventing readmissions, since most readmissions are likely to occur in the first 10 days. So I've seen a lot of great pieces of equipment and packages here, but it does seem like this human element, this person on the other end of the line, is a really important piece of the puzzle. What else? I think it's also important, we've been talking about information. There was a lot of data collected through these systems. So we've got the video chats, we've got the clinical measures, and we've got the patient questionnaires as a part of our process. And all of this information is available through this HIPAA compliant web portal. But for us, one of the limitations was we would have to take that data and enter it into our system separately. So that's why this Epic integration is going to be really critical, I think, for everyone going forward. I thought this might be interesting just to see a sample case for us. This one was not in the pilot because it's a CHF patient, but you can see this patient, fairly young, living at home, not compliant. He answered some questions that indicated that he was having shortness of breath and leg swelling, and this triggered a call to the coordinator who had the patient turn the video on himself, and the coordinator could then see the extent of the swelling and really understand what some of the issues are, including the pistachio nuts on the ground, which would indicate something that this person probably wasn't supposed to be eating and may be contributing to the problem. So in any event, the coordinator was able to have a nurse involved, come over to the house right away, and then actually intervene, schedule the appointment with the doctor the next day, and a readmission was avoided. So that was a pretty good success. One neat thing about this system is that you can also video triage the physician at any point in time, so then the physician can be involved in deciding the next steps. So, okay, lastly, I'm just going to talk about our results, which were compelling. We had some success here. We had a fairly small sample, but overall, we had a much lower incidence of rate of readmission for patients in both of our diagnoses areas. So COPD, we had a rate of 9.1%, which with a much higher expected rate. And then for pneumonia, we had 0 patients readmitted. So overall, we think this was really successful and absolutely contributed. The telehealth was really the main feature here, the main change in the way we do care. So I really think it shows a success and potential for telemonitoring. I have a couple of things I wrote down that I'm going to read. They're not up there, but to Tommy's point about getting the patients engaged and involved and what they think of the equipment. For the most part, 70% of our patients who did the telemonitoring wanted to keep the equipment. And some of their comments are patients felt more in control and involved in their health. They had peace of mind that their condition was being monitored, and they really liked receiving the early response from the physician. And then for the physicians, they also really loved it. They thought that it was terrific that they got an immediate response by the care team, and they appreciated all of the data that they received because it really helped them between patient visits to know what's going on with the patient. And I guess finally, the fact that another team could handle these less critical issues and leave the more challenging ones to the physician is really a big deal, and it helps eliminate unnecessary doctor visits for perhaps less critical issues. So at this point, We're really planning on expanding to probably mostly a high-risk patient population, which could mean any number of the 6 conditions that hospitals are penalized for if there are readmissions. But we have a couple of challenges, and I just thought I'd mention some of the things that we're looking at, some things that will be really important for us as we think about other new vendors and patient populations. The first one is the clinical data. As I mentioned, if we have a big group of patients, we can't be taking the data from the monitoring and entering it into the record. We really have to have integration with our Epic record. Second is really having a way to deal with the patient's willingness and ability to be monitored. And I think some of the bigger barriers were physical and cognitive, and I've seen some great systems here today and actually earlier this week that I think would really solve the problem. I definitely want to talk to you some more. And then reimbursement. So we know there's some reimbursement issues. Patients really don't want to pay for it right now, and I'm hoping that we can get around that because there really is a strong value proposition. And I guess the last one I would say is, especially in our area here, is having interface and perhaps staff like a coordinator who are multilingual and able to address our diverse patient population here. So that's all I wanted to say. Questions?
Any questions?
So I did want to talk to you about reimbursement or ask you about that because a couple of days ago we had a presentation where I think by the Noridian person who said that Medicare doesn't reimburse for when telehealth is used in the home. Right. So did you get a waiver because it was part of a Medicare innovation project? And, you know, is that the challenge that you're talking about? The other question is, so then are you now focusing on commercial payers then to extend this?
So for the first one, we could have gotten a telehealth waiver, but we didn't because we weren't quite ready to do telehealth at the beginning of our bundled payment program. But that is definitely, you know, a barrier for us. I think that one of the issues for Medicare patients is that we can't provide a product or something of value to patients that's greater than $50, otherwise it's enticement. And so there are some barriers that way, but from a reimbursement standpoint, we're hoping that it does, you know, come through. You probably want to jump in.
So given that information, have you at all thought about, from a vision perspective, partnering with entities like assisted living facilities and senior homes and things like that, and kind of taking this to the next level in a more organized fashion?
Yeah, so it's rather nascent, but what we did is we invited all of the senior centers from 12 different cities across the Silicon Valley to start talking about how to better connect to seniors around isolation in the home and to do it in a more organized way. By the way, they're as stretched as anyone, if not more, and they have no margins and no ability and flexibility, quite honestly, from what they're already mandated to do. So it's not an easy, I mean, you would think, oh, that's a great idea, but in fact, it has been challenging to get their attention and priority setting around how do we help connect to seniors in the home. But you had another follow-on. Go ahead. What?
Quick one.
Please.
You might start thinking about the idea, because this is a value-add service.
Mm-hmm.
This is a value-add service to the elderly population.
It really is.
And, I've got 4 elderly parents who are in this kind of environment, and this could be just kind of an add-on service that's offered to those clients. And I'm pretty confident that many, if priced properly, would add this to their apartment within the senior facility and move away from the insurance part of it.
So I think that the distinction should be from senior centers to retirement communities. I actually think that in the independent assisted and SNF retirement communities, you have a better opportunity. We did a trial about 5 years ago using Vigo, which is a robot that goes, you remember Vigo. But we did try to work with the communities, because the point is the seniors were wanting to get more actively engaged and trying to have day-to-day monitoring. So there's a tremendous opportunity.
And I'm thinking just smart apartments.
Yeah, smart apartments would be the way to go.
Any other questions? Okay.
You know, I had read that one of the top trends is that pharmacists are going to start doing home visits. And I talked to a pharmacist, and he said that his hospital actually pays for him to go out because, you know, the savings. And, you know, because of the waste related to medical management and medical adherence, which is $300 billion, it seems like there's an opportunity, you know, for pharmacists to use this. So, you know, kind of given Gary's question about hitting the home centers and, you know, they're stretched, you know, is there an opportunity, you know, to use this for medical adherence?
So in our partners, their partners like Sutter as an example, they actually do pay for different levels of different skill sets, if you will, whether or not it's physician, NP, social worker, and pharmacy. So they absolutely do use those different skill sets to address the polypharmacy issue in the SNFs especially.
And we actually have a set of care team members that includes a pharmacist and RN who go out to patients' homes, but the pharmacist does not regularly do that. It would typically be an RN going out to assess what are the current medications at home, and for the discharging patient, are there any that are in conflict, and then make recommendations for change. But I do like the idea of having the pharmacist be available with the patient as the patient goes through the medicine cabinet with the video and checking what's there.
I had a question in regards to the type of service you're using telehealth for. Other than just senior care, is El Camino looking to expand to perhaps mental health, like psychiatry?
Yeah, we have done telehealth for psychiatry for a long time. So in mental health, that is, I think back in the 90s, and most of us became familiar with telehealth. That's a large part of what we did our work in was mental health. Right now, we do telepsychiatry at night in the ED, you know, on the off hours, since we don't have a psychiatrist available necessarily 24/7. So the answer is yes, we do.
Hi, thank you for giving us a great talk. Yeah, you know, my question has to do with sort of the flow of how patients are admitted, taken care of, and then discharged. So from the hospitalist perspective, the patient is discharged, we write orders, and after that point in time, we don't know what's happening with them. Now, we assume that the primary doctor knows what's going on with them, but that's not the case either. There's this week where things can go wrong. Typically, we try to get them to see a doctor within a week. I'm not sure how often that happens, even though we make this appointment for them. I feel like there's something missing in that equation. So, you know, this data is meaningless unless it's actually being seen by someone and there's some, you know, there's some interaction so that we can make adjustments. I feel that the patients that I discharge, if I had some insight as to what was happening with them, I could make some changes readily that would keep them out of the hospital. But yet I don't have that opportunity because hospitals don't seem to have that much insight. Sorry.
Yeah, I know, and you know, it's embarrassing. I feel like we let down our patients when they leave the hospital. I mean, I really do, and sometimes we let them down when they're in the hospital. I'm not saying we do everything well, but to your point, I've been involved in two bodies of work that speak to your point. One was when I was with Alina in Minnesota. What we did is we made sure that every single patient that was discharged got their discharge meds in hand before they left. And, you know, yeah, delayed discharge sometimes people would kvetch, you know, by an hour. But the point was there was a study done that less than 40% of the patients that get a prescription actually fill it. So our point was let's at least get the medications in hand. So to your point, that was one way for us to address the medication compliance issue. Now that doesn't mean they're going to take it, but at least getting that in their hands made sense. So that was one. And the other thing we did is we made sure that in the clinics, the same story, we placed pharmacies in our large box clinics, if you will, and to make sure that the pharmacist downstairs, so that the patient wouldn't have to stop at the pharmacy on the way out, on the outpatient side. And when we're treating over 2 million patients, this made a big difference, is that we actually had the pharmacy clerk or the tech run the meds up to the clinic site, which is very rare. You don't see that happen very often. But the whole point was to get those meds in hand. And then back to the point about when you discharge a patient, where do they go? They go into this big black hole. We did a pilot that, you know, I'm embarrassed to say it fell apart because we didn't have the resources. But the point was in the ED, every single patient that was seen, and we called treat and street, they went out, is that we the pilot wanted to make sure that the patient saw either care coordinator or social worker to make that appointment. And the way that breaks down is exactly what you said, is how do you know they actually went? So until we get these different connecting pieces, it's nice to make an appointment in 24 hours, but do we really have records on did they show up? And oh, by the way, did their outcome change? So we have a long way to go. I completely agree.
Yeah, the only thing I would add is, Epic is, despite some of the issues with it, I do think there's a lot of potential for connecting acute with all of the providers out in the community that touch the patient after they leave. One of our phases of implementation is really to get as many of our community physicians up on Epic as possible so that they can link to the records. And we have an outpatient module now that we implemented called Healthy Planet, whereby our outpatient case managers can actually document all of the information that's related to that patient's care and status after they've left. So, it's not here right now, but I think it's really coming and will help a lot.
So Tomi, may I ask a question for you? So in your talk you mentioned, so often as a hospital CEO, you guys are just so busy with so many priorities. Sometimes telehealth, you do a pilot, it doesn't, so just on the outside of telehealth, what are the top 3 things as a hospital CEO do you worry about or spend time focusing on?
Other than, you mean,
not telehealth,
forgetting telehealth? Yeah. Quite honestly, well, for sure, we always spend our time on quality, and I mean that sincerely, is if you don't have quality, then you just don't have anything. So usually things cascade from that. So in order to have premier quality and always to be in the top decile, which is our expectation, is you have to have really strong physician leadership. So for me, it's around the physician community. I think a lot about how do we make it easy for physicians to come together and talk about advancing health in the community and what are the right ways to do it. Technology, number one, but also the personal connections and what have you. So the whole physician community, I just think about a lot because we don't have enough physicians, in my opinion, in leadership roles to really think about strategy and then how do you convert that strategy into actually better health outcomes in the community. And I think I'm not minimizing the roles of nurses or other clinicians, but I'm just saying I just find a void sometimes of physicians coming together with common mind and common purpose to really drive community health. So that's one. And that's just in my experience. You can't ignore the payers and the aggregation of the payers and how that's going to affect you. It's still a rate game. The conversations are all around rates. They're not around better care and quality and outcomes, with all due respect. That just still is troubling to me, and we haven't advanced that, in my opinion. And then I'll just say one other thing, the employer piece. We constantly try to figure out, how these large employers can better think about employee health with us, because obviously if you have a community like Silicon Valley, when you have this level of stress and anxiety and depression in the workforce, and you have all of these chronic conditions that exist in some of the older companies, not the younger companies, I don't think we do a good enough job, an adequate job, in really linking to the employers and thinking of either narrow networks or how do we really make it easier for employees to work their best and to be present. I know there's other things I think about a lot, but just coming top of mind, those are a few things that come to mind.
Thank you so much. Thank you so much for speaking, and thank you so much.